Yeah, so the treatment factors that affect newly diagnosed patients with newly diagnosed diffuse large B-cell lymphoma include pretty standard clinical features, including age, functional status, and comorbidities. Um, from the perspective of the disease, if the patient has double hit lymphoma, that can also impact treatment selection. For the majority of patients who have reasonable performance status, if they're in their 60s or 70s and don't have significant comorbidities, R-CHOP is still going to remain the standard in the current era outside of clinical trials. If they have significantly advanced age into their 80s or late 70s with comorbidities or really poor performance status, starting with less intensive regimens such as mini R-CHOP or just palliative treatment with steroids, Rituxan, and cyclophosphamide, or vincristine, like RCVP is often used in that setting. That's appropriate. But again, for most fit patients who can receive R-CHOP, that's still the standard outside of double hit lymphoma. And as we discussed, if a fit patient has double hit, that's when a more intensive regimen is usually offered. So the stage of diffuse large B-cell lymphoma can impact treatment to a certain extent. Most patients are going to be advanced stage with stage 3 or 4, depending on the extent or absence of extranodal disease. And again, for those patients, 6 cycles of R-CHOP is still standard therapy. In the case of limited stage, so a true stage 1, there are data from recent trials that show for low risk early stage patients, it's appropriate to offer either 3 or 4 cycles of systemic therapy with R-CHOP, sometimes followed by radiation, but increasingly we're seeing data that suggests that if you achieve a complete metabolic response, for instance, after 3 cycles of R-CHOP, completing systemic therapy with 4 cycles and omitting radiation is still reasonable and achieves very good outcomes for early stage 1 or 2 DLBCL. For germinal center or non-germinal center, which is typically activated B-cell subtype, there have been a number of trials over the past decade which have attempted to improve the outcome of patients with higher risk non-germinal center DLBCL, which has usually an activated B-cell phenotype. Investigators have attempted to introduce proteasome inhibitor, bortezomib, lenalidomide, BTK inhibitors such as ibrutinib, and to make a long story short, all these trials to date have not been positive. So despite the significant biologic rationale for introducing targeted agents for these subtypes of patients, particularly the ABC subtype, none of the studies have panned out. And some of this may be related to patient selection in terms of not getting the higher risk patients onto the studies. But another part of this is likely that the method of assigning subtype has been too crude, and we really need to move to a more advanced molecular testing method to discriminate the subtypes and then assign targeted agent pathway inhibitors, targeted agents in those specific pathways for those specific subtypes.
So this is an important aspect. How you, in reality, when you see patients having comorbidities and cardiac issues, neurological issues, etc., that we know that this is a difficult situation. The definition is changing, the geriatric assessment, but basically you face a patient that has, for example, older patient and more than 80 years old and can have some comorbidities, so you can use an attenuated form of a R-CHOP, which is the mini CHOP, that could be very helpful. And if the patients have cardiac dysfunction, we can replace the doxorubicin by etoposide or gemcitabine or liposomal doxorubicin. There will be some more, sometimes bendamustine, Rituxan, not really, but there will be some interesting combination with antibody drug conjugate that are like POLA that are being looked at in a frontline setting, and other combination that hopefully that will emerge as a possibility. And then what's important is that in a patient who are older, I think it's important to mention here, the patient that are older, frail a bit, but not necessarily cardiac dysfunction, one thing that works really well is to give them somewhat of a pre-phase with vancomycin, rituximab, and steroids for 5 days, and then they come back a week later, and then we can start them on our CHOP. And these patients do really well. And there's finally emerging novel therapy, as I mentioned, that might offer an opportunity to replace chemotherapy in that setting. So there's the R-square ibrutinib data from MD Anderson from the SMART STAR trial from Westin, and that had shown a very high response rate and CR rate after an induction that is basically non-chemotherapy option, with an overall response rate of 80% and CR of 36%. And this patient can receive an abbreviated course potentially of R-CHOP if they're elderly. And as I alluded to, the polatuzumab and BR that is being, the POLA is used in a relapse refractory setting. We'll talk a little later about this, but is going to be integrated as well as tafasitamab integrated in a frontline setting. So we are building up by adding this novel therapy that might allow us to treat even better these patients that you alluded to that have comorbidities and issues that prevent them from using anthracycline.